Good morning and from New York, and good day from wherever you may be around the globe watching us via the internet. This is the monthly endovascular, peripheral vascular, specifically for today, webcast regarding a complex femoral interventional case. I'm George Dengas from Mount Sinai Medical Center in New York City, and just before we go to the cath lab, I'd like to just inform everyone that in case they've missed any of the any parts of the previous webcast, or they'd like to review any of our previous webcasts, you just go to the archive button at your screen, and you can just scroll by that. Similarly, if you get tied up during the day and miss out parts of today's webcast, you can catch up later and see the rest of the case through the same internet access at the archives button. Please send us any comments during the case at the info@peripheral.interventions.org, and we will be able to address them during the case live. I'm going to bring it up to the operators and the in-room moderator to be answered, and this way we can have an interactive discussion. I would also like everybody to know that the companion webcast is at ccclivecases.org, ccclivecases.org, and as you know, this website is dedicated to peripheral vascular interventions once a month, the next one being on Wednesday, March 27th, same time of the day. And without any further delay, let me introduce the team in the cath lab room today. Dr. Krishnan, Dr. Wiley, Dr. Babayev. Can we go there? Good morning, PK.
Hi, good morning, George. And on a rainy, wet morning in New York, our very good friend, Dr. Babayev, has come from NYU Medical Center. As all of you do know, I mean, he's been with us before, supported us before, and we're very grateful for him to come on this difficult day. He's the Director of Endovascular Services at the Cardiac Cath Lab in NYU Medical Center, and he's obviously a world-class interventionalist, and we're really grateful to have his input. Thank you so much, Anwar, for coming. I've also got Dr. Jose Wiley, who's always with us for these cases, and who's our Associate Director of Endovascular Services here in the Cath Lab at Sinai. Ray Lascano, our nurse practitioner, who is invaluable to our work here, our endovascular nurse Elizabeth, Ricky, our tech, and obviously our fellow Rohit Buria. And so, we're very excited to present this case. And as I take some diagnostics, I'm going to have Dr. Wiley present the case and get Dr. Anwar's thoughts on this.
Okay, good morning, everyone. This is a 81-year-old gentleman with a past medical history of diabetes mellitus type 2, hypertension, hyperlipidemia, who was complaining of left hip, thigh, and calf claudication occurring at less than 1 block, essentially a Fontaine Class IIb claudication. The peripheral angiogram had revealed severe calcification of the common femoral artery, and the plan for this case would be intervening on this common femoral artery, which, as what we stated before, is severely calcified.
Okay, so this is a gentleman who also has ischemic cardiomyopathy. It's a patient of mine from Staten Island, recently underwent coronary stenting ×3, and has had issues with his EF and so on and so forth. So he's as Dr. Wiley so nicely presented, has history of diabetes, hypertension, hyperlipidemia, and he's very, very much limited about with his claudication. So I don't know what you're seeing right now.
We're seeing the SFA, but this
right.
is SFA.
So I'm just going to do some diagnostics, and as we always talk in our courses to everybody, is that proper technique is the key, and I think here you always need to know good inflow, good outflow. We know that he has no iliac disease from a prior angiogram, and now we're just showing his SFA popliteal system, and you can see here that he has, well, we'll go over the angiogram in a second, but he has approximately, it looks like 3 vessels, but very, very slow flow, and you can see why he's so symptomatic. So let me just tell you what we've done, and I'll have our good friend Dr. Babayev here to tell us a little bit more. C- guys on what he would do, and just some thoughts on approaches. He's kind enough today to also give us a lecture on the management of common femoral disease, which I think is very, very important and very controversial, because I think as endovascular specialists, we think we can manage it with percutaneous options such as this, but there are options surgical which are certainly come into play, which I'm sure he'll comment on. So you can see here he has a calcific common femoral stenosis. Now, just to let all of you know, we had a very difficult time wiring this. We tried with an 014, obviously it was buckling on us. So our whole process of getting up and over, just for teaching purposes, is we did not want to cross this blindly. So what we did was we actually put our wire into the internal iliac artery, and then took our universal flush catheter up to the internal-external bifurcation, then redirected that into the external iliac artery, taking great care not to cross this since we knew this was there. So then we tracked the UF catheter down to the mouth of this, or I should say the proximal edge of this lesion, and then we were able to wire it with a straight glide. We tried 014, we were having a little bit of difficulty, but it went through with a straight glide. C-, please. So then what we did at that stage is we tracked a 7 French filter minus up and over. And once we tracked a 7 French, guide up and over, we then put the aqua tempo over the glide catheter, so a glide wire. Then we went ahead and advanced the EV3 filter over this and placed a 7mm spider in a very calcified segment, because I think, at least in our experience, in our hands here, calcific stuff tends to embolize more than non-calcific lesions. Then after that, plus please. We did our diagnostic pictures right here, and you can see our diagnostic picture. You saw this one next. So you'll see here that the SFA is quite calcified in the next picture. You'll see here the SFA is quite calcified. You can see the flow is also very limited. Now, naturally, we're injecting proximal to the stenosis there, but you've also got significant SFA disease. So the question becomes is how much is going to be helped by opening the common femoral, how much is going to be helped by doing both the SFA and the common femoral, and I think that's a good question. You saw the runoff was quite reasonable, but I didn't want to waste more dye trying to take pictures, because I know you're not going to be able to visualize.
Well, clearly, we have multi-level disease here, significant common femoral, the SFA, and whatever else may be below the knee. Right. The problem in adequately visualizing distal disease when you have a very super tight proximal disease is a real practical issue, because you got to give a lot of dye in order to properly see what's going on very, very distally. That may be a little futile at this point, because we should be able to get easier pictures after revascularizing the first lesion. Right. If we were not targeting an intervention, one could say that we can advance a end-hole catheter very distally and do a better run of pictures more accurately, but I think that's not necessary right now, and this is to just actually orient better people who are not very familiar setting up this case up front. You have a general idea about what is happening, but you don't want to spend 100 cc's of dye taking subselective pictures from high up in this case of multi-level disease. One practical question I have for you, PK, and then we hear Anwar what he has to say about the case. The location of the case seems to correspond with a typical access site. I wonder if the patient has coronary disease. I wonder if there were past interventions a long time ago or something.
That's a great question, George. And I'll tell you, this guy did not have any other workup or any other intervention other than the one we performed through the right groin. So this is truly native. This is truly, atherosclerotic process that he's having. And he's going to be so symptomatic as the lesion is proximal to the profunda. And I just want to ask Anwar what his thoughts are and what his approach would be. Just to comment before he starts talking, our plan here is obviously anticoagulation with bivalrudin, and we are planning on doing a rotational aspirational atherectomy called the Jetstream atherectomy, and with the bivalrudin, followed by any adjunctive therapy. Obviously, I've got great help here and great suggestions from very, very experienced operators, so it should be make a difficult case look easy. So we're going to let Dr. Babayev go ahead and speak about his thoughts.
So, of course, when you have a relatively focal, heavily calcified common femoral lesion, the so-called gold standard therapy is surgery, of course. And atherectomy, some surgeons would suggest, since we have also, in my understanding, distal SFA, severe disease, right, Prakash?
Yeah, severe disease.
Yeah, so
looks like pre-vessel,
right.
Anwar.
So, and some surgeons would also consider doing maybe atherectomy and at the same time percutaneously fix SFA. That would be another option. Or we can try to do everything percutaneously today, and for these particular lesions, when there's so much calcium, in my opinion, you should do some sort of debulking therapy, meaning atherectomy. There are several options we have today. One of them, there are several types of atherectomy devices that do exist on the market and are available. One of them is a pathway device that we are planning to do today. My understanding, Prakash is setting it up right now. That is a rotational atherectomy device that has also, can change the size of the lumen. There is a blades down mode and the blades up mode to increase the lumen size. And it also has a suctioning device on that. But don't be fooled by that. If you have such a calcified lesion, you still can send some debris down, and that's why Prakash put the filter down, which I think is a great idea.
Anwar, do you use any particular filter more than the other, or anything like that for the audience?
Not really. You used for this particular device, you used the EV3 filter, which is kind of convenient thing to do when you have a catheter down. You can simply, like, let's say quick cross or whatever you're using, you can put it in a quick cross and put it down. It's quite easy. If you are using a so-called orbital atherectomy or diamond back, then if you want to use a filter, you should use 017 tip, so-called wiper wire, and only Abbott filter would work with that. Otherwise, if you use any other type of wire, the filter would slip off. The orbital atherectomy, we have started working here, so.
I'm just going to make one pass here. Go ahead, Anwar. Yeah. Keep talking, I'll just make one pass.
So the orbital atherectomy would be another option. It seems to be something that's designed for calcium. Same thing as a coronary rotational atherectomy idea. That could be used as well. And another option would be using TurboHawk device, that special calcium TurboHawk calcium device to do that. Here it's probably not it's not a good idea. Why? Because the lumen is so tight, the device may not go in, but otherwise it's something to consider, will be something to consider anyways.
Anwar, I have a question regarding this. This case is, this lesion is highly eccentric.
Yep.
Right.
What consideration would that be in the rotational atherectomy? Could it be a case that you successfully perform rotational atherectomy to the maximum burr size, and we can talk about what that is. And
right.
If that's still small, could at that point consider the TurboHawk?
Yeah, if you can make lumen large enough for TurboHawk to get in, and eccentric lesions are great for TurboHawk because you can actually do directional atherectomy and point your blade towards the plaque, and that would be ideal. Yeah, sure, that's something to think about. Again, the cost goes up tremendously if you use two atherectomy devices. Of course, we have to keep that in mind. Another thing which is quite interesting, if you look, when we are talking calcium, if you look at two studies that were done with the pathway device, when they did intravascular ultrasound, before and after device was used. The first one was done several years ago, and it's called True Study, when they did VHS or virtual histology IVUS. You all know what virtual histology is. It's an intravascular ultrasound that allows you to look into a content of a plaque and see how much calcium there, how much fat, fibrous tissue, etc. And it's so-called True Study. And that study shows that actually not much calcium was removed whatsoever, and there was no effect on necrotic core, and basically device, it showed that device removes only soft part of plaque. On the other hand, another study was presented at ICET and Leipzig this year where when they did not use VHS, they used so-called planimetry analysis of the intravascular ultrasound. And that showed that, and that is not published yet, and whenever it will be published, we will have a chance to digest it more and understand this better. I'm not sure how exactly that analysis is being done. But the conclusion was that this device does remove calcium and potentially is good to be for use in calcified lesions. So in this particular, you see we got pretty good results here. So it probably does remove calcium, but or fibrous tissue.
You're absolutely right.
Hard to say. So there is more to learn about this particular device.
Right. So can we talk a little bit about sizes of burrs and sizes of the vessel PK?
You know what? I'll tell you, George. I mean, two things. First, I want to just comment. I'm really sorry because for the sake of time, I wanted to do the first pass because, as Anwar said, this is not going to be one where it's a standalone type of case because you're not going to get a large enough lumen size with just one particular thing. So I didn't want to be rude. He's my good friend, and I know he understands why we had to go forward. Why we did that while he was speaking was because, for the sake of time, number one, but also I wanted to just talk about two things we did. One is, as we went, you saw, as Dr. Bobby was speaking, I'm sure they were showing the screen, you saw how we were pecking. And I know in Rhoda, Dr. Babiev, all of us here who teach Rhoda clearly teach that when you're trying to get through a difficult lesion, you want to go ahead and peck and come back. And so that's the same technique I used here that we use in the coronary rotablation. And you saw the patients that all of us will demonstrate in doing such a thing. You don't want to really push this through. You want to let the burr work its way through. So once we went down with the blades down, in this particular device, George, there's three particular devices available. One is a 2.1 3.0, and the other is a 2.4, what is it, 3.4, guys, this one? I think it was 2.4, 3.4, and the other one's a 1.7, I think 2.1, which is for below the knee. So there's three particular devices, and what the first number is what that device acts as blades down. The second number is when you go with the blades up, it becomes a bigger device, gives you a bigger lumen. So what we did here was after the first pass, we polished, and then I went up with blades up again. I apologize to him because I was doing it as he was speaking, but just to get this lumen, now we're in a different situation in the case where now we've either it's fibrous tissue or calcific tissue, but now we've clearly made at least a 3.4 lumen to be able to now decide what's the next step. And I think this is the interesting part, and I think this is where really the bulk of the discussion is going to come. Now the second thing I want you to realize is my partner, Dr. Wiley, he was very, very careful with the filter, and I always do this if the creatinine allows me to, is just to see how the injection is and how the flow is through the SFA once we're done here. So you can see here the flow through the SFA is still slow, but certainly the filter is obstructing, and there seems to be something inside the filter. So you can see here that clearly we're better flow than we were before. The filter is in place, and clearly there seems to be a filling defect within the filter, which I'm sure that will help. My other question to Dr. Anwar is, Anwar, what do you think about the symptomatic relief if we just fix the common femoral versus the SFA? Do you think the common femoral alone would be enough here, or do you think the SFA should also be addressed at this stage?
I think patient is going to feel definitely better. Why? Because you have which seems to be a healthy profunda. Absolutely. With a good collateral below that stenosis in the SFA. So I'm sure his ABI will go up. Will that make him absolutely asymptomatic? It's hard to say. Depends on what his basic level of activity is. He may still have claudication because of the SFA lesion. Sure. So I'll leave it up to you, whatever. It depends on the creatinine ejection fraction, how much dye you used, etc., etc.
Yeah, his EF is around 22%. And so, I mean, I just let the audience know the full story of what's happening. So I think at this stage onward, as you saw scene minus, I'll show you what we're left with the residual. What are the options, in your opinion, for therapy here for our audience? Can you freeze it when it goes over? So you can see here that the lumen went from 99% to, say, 70%, right? 30%, excuse me, from 99% stenosis to 70% stenosis. So you probably have a 50, 60, 70% stenosis at this stage. So I'm curious on what your options would be now.
So there are, in this particular situation, I think we have two options. One is to get another atherectomy that will be directional with a silver hook, or now it's called turbo hook, and try to cut just that plaque. Or second, use something like cutting balloon, peripheral cutting balloon, put it there, inflate it, see how the lesion responds to cutting balloon, and based on that, then decide whether you do need to do some additional atherectomy or not.
All right, you know what? I know it's expensive, but we would like to teach different techniques and different options. But I think the concepts that Dr. Babayev said so clearly are very, very important. You have to, when you look at this lesion as a peripheral interventionist, you should be able to say that the Silverhawk probably will not cross this lesion. So you're probably going to have to do something prior to doing this. Now, we went a more expensive route. I mean, I don't think anybody would be wrong by doing, say, a 4mm balloon or a 3mm balloon, and then saying, hey, I'm going to make my channel a little bit bigger and then go forward with the Silverhawk and cut, like as he suggested before. Or you can run the CSI through with a filter in place. I think all the devices need a filter. But here, I think you know, for the sake of teaching about calcified common femoral as well as for the other options that are available here, we're going to demonstrate the Silverhawk LSC, which is open, which is their calcium cutter. Two technical things that I just want to go over for our interventionalists. So I want you to look at the film here, and you can see around the centimeter sign, you see the Terumo sheath. And then you see around 9 centimeters, or excuse me, around 6 centimeters is where the lesion starts, right? So you remember, you want to give yourself a gap in order to allow the jog of the Silverhawk to work. So in this particular case, when you go with the Silverhawk, what you're going to have to do is use the Silverhawk as your dilator and pull the sheath back. When you pull the sheath back, you have to be very cognizant that you have the Silverhawk as your dilator as well as your filter distally, and you're doing it on an 014 wire. So some of you may feel uncomfortable doing such a thing, but the important thing is you have to understand that if you pass the Silverhawk with this much distance between the sheath and the Silverhawk, what will happen is you will not get enough jog or the actual opening of the blade against the plaque in order to get an adequate cut. So that will result in, you'll do the case and you'll be like, wow, there's no difference, let me just balloon. Well, the reason is that you didn't allow the Silverhawk to actually bite into the plaque. So I'm going to ask Ray Lascano to give us the LSC, and we're going to load that. And I just want to ask Dr. Wiley and Dr. Dangus their opinions on how they would do, what would their next step be?
Yeah, I think that it's appropriate to use directional atherectomy in this case. As you see, there's plaque in the medial aspect of the common femoral. After that, we'll take an angiogram and see if we need any other adjunctive therapy, perhaps our balloon, but let's see what it looks after this atherectomy.
As Anwar answered a little earlier, it's just the eccentricity of the plaque that makes me wonder that also the atherectomy in this case would be the best interventional choice. The possibility of the cutting balloon, if this lesion was somewhere else, that we could also have a bailout stenting favorable option, I think I would favor that one as well. But the common femoral, we want to try to complete everything without putting a stent. So I think giving a chance with a directional atherectomy would be great. And let's see now. And PK, can you give us a detail of how the device is?
Yeah, what's this device? I got to tell you guys, this is just traveling very smooth. A little bit of roughness at that spot. So now I just want to show you the difference in the jog of the device that I'm talking about. And I want Anwar to comment on stenting, because I know the guys in Germany. I know he's traveled to Link a couple of times, and I know he's been at the conference. I'm curious to see what his thoughts are on the stenting of the common femoral before we do anything. So let's see how this cuts here. You can see I'm torquing the device, whoops, as it just wants to roll back here, but I'm torquing the device towards where I think the lesion is, and obviously there's a lot of tension on this because of the tortuosity in the iliac, so I'm going to kind of keep it right there. I'm just going to make a conservative pass without pulling it back. Go forward on. So I'm just going to make a very conservative pass. I'm actually a little higher than I should be, but I just want to let the blades work. So here what I'm doing is, all I'm doing is just letting the blades work. I can feel a lot of vibration in my fingers. Now you can see it jumps, and that's really what this catheter really does, and that's why the filter is important. It's actually a very aggressive cutter that actually chops across the calcium. Off, please. So that actually chops across the calcium, because we're stuck here, as you can see. So we're going to come back a little bit, and now I'm going to go ahead and torque it back. So while I'm going to fix this device in the area that I want, and I'm going to show me above, please. Now I'm going to show you what I'm going to do with the sheath here. Above, a little higher. Show me the sheath. So okay, so what I'm going to do is I'm going to fix this, and I'm just going to pull the sheath back. See? Now this is not something, now you can see the device, you have to keep this straight. So you can see the device, show me a little higher. So you can see the device clearly allows me, acts as a dilator. And now do you see the bowing of the device, George?
Yeah.
That bowing of the device allows the device to do the work and allows it to abut the plaque, okay? So now I can look at obviously I've got my cheek monitor on this side, which is telling me that I need to start this cutting around 6. So I'm going to fix this, I'm going to come down to 6, which is right about here, right? Whoops, and it jumps because of the plaque. So I'm going to torque it again. I'm going to fix it here, torque it back to this side. Okay, there you go. I'm going to hopefully it stays, and then I'm going to ask Dr. Wiley to start. On. Now I'm just going to try to come slowly. Let the catheter do the work, guys. Don't try to push it through. Just allow it to work. You've got a filter distally that's preventing the embolization, or at least might be getting full right now. And Anwar will talk about techniques on cleaning up filters. But clearly, this particular device, you have to allow it to work. See, there's a lot of grinding there. And, it's going to pop right through at this spot any second. There it goes. Off. So now I'm going to go ahead, pull it back. It's a little bit better. And I'm just thinking whether I should even walk my catheter back even further above, which makes me a little uncomfortable because of our external iliac. But I'm going to come back a little bit more. But here, I got to tell you, the problem here is the tortuosity of the native iliacs makes it a very difficult, come down, that's good, makes it very difficult for us to do it. So I'm going to come back up again, like I said, to this point, and I'm just going to come off this plane a little bit and try to go a little bit more towards the plaque and start a little more proximally. Like, it's really having a tough time, George, with that iliac. There you go. Now I'm going to ask Dr. Wiley to turn it on. So I'm going to try a little bit deeper cut here. Definitely seems to be moving further and much more smoother. And right around this area, since I've got my glow tape. And I want to get all of you excited about using glow tape or some sort of marker tape, whether it's glow tape or anything. It doesn't have to be one particular company. But the point is you really want to know where it is. So it's really grinding here off.
Yeah, it's very helpful to know exactly where the 6, 7, 8, and 9 markers are, because that's where the plaque is. Are you want to walk it back now?
Yeah, now I'm going to advance the sheath. I'm going to have Wiley hold my Silverhawk in a rail fashion, and then show me above, guys. Above, higher. So I want to make sure I don't buckle into the aorta. Go low mag, guys. Now these are the things you need to think about. Every action has an equal and opposite reaction, so you definitely don't want to buckle back into the aorta. So as it's coming back a little bit, which we expect it to, now Dr. Wiley is going to walk it out. I've got much better positioning here. It's not, it didn't buckle. Show me down distally, please. Show me my filter. And our filter is also very good. Good. Show me above. Now Dr. Wiley is just going to walk it out. Somebody has to hold positive and keep the Silverhawk off. Anwar, what are the other things that you would do different here, or any other suggestions?
I would do exactly this, what you just did, and next step is take picture, see what you've got, and then make a decision how to proceed. So hopefully we cut more plaque. On the other hand, the way the device was behaving, it looks like it was struggling on that calcium.
Absolutely.
So I would not be surprised if we will not see much of a change, but we hope that we will. Another thing that we have to emphasize, whenever you use this calcium catheter, this particular Turbahawk version of calcium, you must use a filter. So without filter, you cannot use this device. So let's see what we've got now.
So it looks about the same to me. What do you think, Anwar?
Well, it looks a little bit 55 to 60%.
I think it looks a little bit better. It looks a little better, but the way it was behaving and cutting and just slipping through that calcium, it's just probably very stubborn plaque there and a lot of calcium.
Yeah. You know, what do you think about this whole theory, Anwar, about changing compliance of the vessel? I know with CSIN pathway, you definitely do a little bit like we do in the coronaries. Do you think that's applicable here?
Well, at least we hope so, and I think you must do that in order to get. If you would try, we know that from even SFA experience that if you just deploy the stent, self-expandable stent, in a heavily calcified lesion without doing some sort of debulking to improve compliance, you're going to get a horrible result. Especially if you do intravascular ultrasound afterwards, you're going to be like surprised in a bad way what you're going to see. So if you do debulking, then aggressive predilation, preparing the vessel for the self-expandable stent, then you are much better off getting a good result.
So you can see the other thing we do is we also take a picture of the filter just to understand what's going on within the filter here. And you can see here when we took a picture of the filter, I want you to concentrate around between 29 and 30.
Exactly.
You see a filling defect inside the filter?
Yeah, there's some plaque there.
There's some plaque, and that's exactly the point, George. I think you clearly make the point that this is not thrombus that you're going to send down. This is not something that's easy to deal with. This is something that's very difficult to deal with. I know Anwar has taught me a lot of techniques on dealing with distal embolization. I think it just, you go through a lot of things in your career, and you share your thoughts with each other as colleagues. And he was kind enough in our course 3 years ago, Anwar, right? When we did a calcific SFA, and we had, thank God we had a filter down, but we massively embolized distally. And Dr. Babayev was on the panel and was on the podium, and he suggested something, and it worked for us. And I want to ask him to go ahead and suggest. Anwar, I want to present a case to you. If I'm a new guy, I'm out there, I do exactly what we did now, but I happen to be a little unlucky, and I've got no flow in my filter, and I've got all this clot down, but I've got good inflow because I got the nice result up top. So what would your algorithm be in terms of if you were there to help that person, or for them to think about what are the steps they should do? Just to set up the scenario, I've got a 7 French up and over. I have a calcific lesion. I did atherectomy. I've got a filter across. The filter is full, but there's no distal embolization yet. So this is the scenario, obviously angiomax, et cetera, et cetera. So I wonder whether you can walk through what you would do.
So it depends how bad the situation is. Sometimes you see it's not just filter that is full, but it's above the filter. There is a column of dyes sitting there, and nothing goes through.
That's the scenario.
And it's a way above filter. You see that clot or whatever debris you have. In that case, do not try to pull the filter using your usual filter retrieval catheter, because the whole thing is going to spill and everything is going to fly down. What you want first to try to suck out whatever is sitting above the filter first, and you can use any kind of catheters. You can, again, it depends on what you were dealing with. If you are dealing with like this particular case, when there's a lot of calcium, most likely it's chunks of calcium sitting on it. It's a one story. If you have a relatively fresh occlusion, thrombotic occlusion or whatever embolization with the thrombus, and it's a different story. So if it's a soft stuff, you can simply try to do something like Pronto V3, try to suck it up from the above the filter. If those are big chunks, the best thing to do would be either try, if you have a 7 French sheath, try 7 French multi-purpose coronary guide. Bring it all the way down to the filter and just start sucking using a big syringe from everything above the filter. What also works really well is a 90 centimeter 5 French shuttle sheath that you can put through the 7 French sheath and advance it forward. Remember, you have a 014 wire, so this sheath may not go down easily, so what sometimes helps to bring it down, if you put 018 wire, stiff 018 wire, to support it next to this wire, and then deliver that sheath down over those 2 wires. And then you use that sheath to suck out everything, and then whenever you see that you clean it up from the top, then you slowly bring it down and pull this filter into that sheath and remove that as a unit. And that will decrease the likelihood that you're going to spill something down.
And I think, to the audience, I think these are really incredible points, because I think, what happens, what the first knee-jerk reflex is what Anvar told us not to do, which is pull out that filter and everything will be fine. Well, the point of the matter is the filter is going to get overwhelmed, and then you're going to have the column of stuff above the filter that he so nicely described go all the way down, and now you're in a world of hurt. It's not something that you can angiojet, because usually it's not just thrombus, it's got all sorts of debris in it. So his technique of this aspiration that he so aptly described, I think really, really works the best in this particular case.
Just to summarize, we do not insert any aspiration device over the filter wire, which is, I think, could be a common misnomer. We have to put another wire inside the filter in parallel to the filter wire, so to speak, and then do whatever we have to do over that, so we can actually go inside.
I think that's a great point. I just
want to clarify that. Anvar said it, but I am not sure that as you were describing the full procedure, this was kind of realized and appreciated as an important detail by the viewers.
George, I got to tell you could probably do either or. I think if you want to get debris from inside the filter, like this particular one, which I don't think will be a problem to capture, but in that case, then you may want to do what you said, put a wire inside the filter. But as Anvar said, sometimes if you take a 7 French catheter or sheath, or 5 French sheath, which is a 7 French guide, in lumen, if you take it over this wire and just place it proximal and just pull back with that real 20, 40, 50 cc syringe, depending how strong you are, you should be able to suck most of it out. But clearly, I think both techniques are applicable here, and I wanted to go over that because that's a real complication. And one of the things that all of us here who spend our time talking to you guys, we really want you to anticipate the possible complications that you may have. And this is a possible complication. So that's why we anticipated by putting the filter, and obviously with Anvar talking about what to do if, God forbid, it does happen, then you know how to deal with that complication, so this way you're not going to have an adverse outcome. So now I'm just going to go scene minus here to Dr. Wiley, and I want to ask all of you guys here. Now I'm going to throw this out to Dr. Anvar. What do you think about stenting this versus ballooning it versus cutting ballooning it? And please give me your options based, especially on ballooning, on how you would size the balloon and what type of balloon you would choose.
Yeah, well, the general recommendation especially for common femoral segment is 1-to-1 sizing balloon-wise. I would try cutting balloon here and use something like Boston Scientific Flexitome, peripheral cutting balloons, and see what I get. Again, ideally you don't want to stent common femoral artery, but you can. There is two papers from Bonvini and Zeller group basically describing the stenting in the common femoral. I think they stented about 38% of the cases, and stenting had a better outcome, less restenosis, etc., etc. Again, you don't want to put stent there, but if you have to, you should.
Right. So, I mean, I think in taking that, I mean, I don't have the Boston cutting balloon on our shelf here.
Well, we
do have the angioscope.
The angioscope is an option. Let me just put one particular procedure detail is that the lesion, as your viewers appreciate, stops around 8.5, whereas the bifurcation is about 10. So that's actually a luxury in this case.
Yep. But
that allows you even bailout standing or whatever to be a little bit less troublesome than a case that would be truly bifurcational, extending into both branches.
Right. George, you know what? One thing I'm going to do here is use a larger angioscope because I know I'm undersized. The angioscope that I have here is a 6.0, which is the largest one that comes. I know my vessel is at least in 9 or 10 here. So I'm going to be conservative here because I know my lumen at that area is not a 9 or a 10. So probably close to a 6, maybe a 7. So I'm going to go up here very, very slowly with this angioscope. Obviously, I'm a little higher and a little lower, but I know I'm undersized because I don't have a bigger cutting balloon here.
I think you're undersized even to the SFA, so I think that's pretty safe. And exactly. I like the idea of using a long balloon, so this way you accommodate the lesion much better.
Now, Anvar, would you ever use a high pressure balloon here?
And it's bigger than we thought, huh?
No, I would start with one of those possibly cutting balloons and see what I get, and then decide what needs to be done. Yes, if you cannot achieve anything with this, then I would try to do aggressive balloon angioplasty, maybe high pressure balloons. The good thing about this particular case, the lesion is relatively short, and you have a room to bifurcation, I think a couple centimeters, and above you have some room. So it's been shown that, and it's general recommendation, if you stent common femoral, you want to get the shorter stent possible.
Right.
So to leave room to yourself for future interventions. You can go below the stent, above the stent, if you have to get the access on that side. So for this particular case, it's pretty good case for stent if you have to put the stent.
Now, my question here is just to, again, for you guys, all of us here, but especially every experienced operators and also the audience, what would your endpoint be? What's your endpoint here? Do you say to yourself, I want a common femoral that's back to 8, 9, 10 millimeters? Or would you say to yourself, I have a 1 millimeter or less than 1 millimeter common femoral, but I'm going to make now that a obviously 6 millimeter common femoral, and that would be my endpoint? Or would you say, one or the other? Obviously, that's going to be your options, because the more you do, obviously, you could have adverse outcomes. You could dissect this, you could perforate this if you go with aggressive balloon dilatation, ending up having to use coverage stents, etc. So the point is, question to obviously Anvar first, then George and Jose. What's your endpoint? Come back. Come back.
The endpoint, I guess, we're not trying to get the result in such a large vessel the same way we are trying to get the result in the coronary artery.
Exactly.
So I think I would be fine with having for this particular size, probably 6.0 or 7.0 stent there, or size of 6 millimeter lumen. If there is no dissections, no flow limiting dissections, no major complications, probably you can get away without putting the stent there.
Yeah. So I mean, George, yourself.
I think the more important thing is the absence of a perforation or a major dissection in this location, because then you're going to be obliged to, bail out stenting, cover stent, etc. I think if you get a lumen around 6 or 7 or something like that, will be very, very rewarding, and a residual stenosis of 30% will be acceptable in my mind in this location.
Jose?
Yeah, I'm not concerned about the degree of stenosis left, as long as we've decreased the gradient. If we have less than 10 millimeters of mercury, I'll be okay with
so Jose,
residual.
That's a very interesting point. So say you do this and you have a 20 millimeter gradient. So you know that the gradient was probably 120 before we started. So would you be satisfied saying, listen, I know I've got SFA disease, I know I've got, but clearly this was above the profunda, and now I've got a 20 millimeter gradient in a guy. Let me stop here, allow him to walk, do what Anvar said, check him out, see him clinically, and then bring him back? Or would you say, hey, listen, I'm going to treat the gradient?
No, 20 millimeter gradient is not that high, and someone that probably was very limited initially, I'll probably just stop there and have him ambulate, see how he does. If the symptoms have significantly improved, there's no reason on trying to dilate that vessel and perhaps dissect it, just trying to make a gradient.
I think what I really want to point out to the audience is the thought process of everybody here in this room, and as everybody's experience level goes up, you will realize certain things. Is that, first of all, Anvar's point about it not being a coronary artery. I know there are a lot of cardiologists who are doing peripherals, and I think it's important to remember that the outcomes are not the same if you don't have an undilated or a perfect result. Obviously, the coronary's outcomes can be catastrophic. Here, the whole point is you're trying to make the patient feel symptomatically better. So that's one. So and what Dr. Wiley's point about gradients is also important, whether you're doing iliacs. I know we've demonstrated in the past with iliacs that how this looks. It's not a question of an angiographic look. I want all of you in the audience to stop worrying about how it looks, and more importantly, think about what the physiology of this particular disease release process is. Anwar clearly pointed out earlier, and very, very nicely, that here you had a profunda and the SFA that was obviously compromised by the stenosis. So you have two major channels that are compromised by the stenosis. The profunda collaterals via the geniculate would not have been as effective. By opening this and not compromising the profunda, now you clearly are able to get flow through the collaterals of the profunda as well as antegrade through the SFA. So I really think that this is the thought process. I don't know what's right or wrong in terms of what you're going to do for your patients, but I think it's important to follow a sound thought process.
I think would be a very good process to remove the filter perhaps and use a time to get some pictures of the entire leg very clearly. I think you've achieved a great result. I don't think we have first of all, we don't have a perforation, and I don't think we have a super traumatic dissection that may involve the distal branches and all that. We have none of that, and I think we have exactly a very safe result. I would allow the patient to ambulate, study again, and perhaps evaluate the need to perform a SFA angioplasty later on regarding of how this patient is going.
Now, George, what I've done here, since I have you and Anwar and Jose, I've dropped an intravascular ultrasound, and this is again for teaching purposes for all of us to understand that we don't recommend that you do this on this case, because I really think it's going to teach us to really express on what are the steps that we're going to do and what we dealt with. So right here, intravascular ultrasound.
Good. Let's take a look. Please put the IVUS on the screen, please.
So you can see the IVUS on the screen. Now I want to tell everybody where the IVUS is. The IVUS is around 10 and a half, so just distal to the lesion. And I'm just going to pull back. You can see you have, I'm just going to pull back slowly. And you can see here you've got a lot of calcium. You see those spicules and plaque. These are the disrupted spicules and plaque. And you can see what Dr. Babayev was saying so eloquently, that you have this eccentric type of lesion here, especially as you come across. But look at the size of the lesion. Now I'm in the heart of the lesion.
Are you pulling there? Yeah, I was going to say, everything looks so huge.
Yeah. I'm in the heart of the lesion. You do have some flaps, etc., but you can see here the eccentric plaque with the IVUS dropout that you're having, which you would anticipate. But clearly, you don't have any true horrible, dissection or anything like that hanging out. So
more disruption, I would say, more disruptions than major dissection flaps, which is consistent with the angiogram. I think that's a great result. They're very, very stable.
So I think what I'll do here is go ahead and can you somebody just check who's calling me, and just go ahead and retrieve the filter as you suggested. Can you give me the filter retrieval device, guys?
Yeah, let's look at that, because that will be interesting to see. One of the risks of filter retrieval in this case is that the filter retrieval catheter may catch in the various eccentric calcifications, etc. I don't think so, but anyone who's performing it needs to be cognizant about that and view the catheter as it passes around 5 to 10 in the tape scale.
Anwar, any comments? We have 10 minutes, and I just want to, while we get the filter retrieval here, what's going on, guys?
I think we have a very nice result, and it's great that you did IVUS that actually confirmed the fact that you can get away with atherectomy and balloon angioplasty. We definitely modify the plaque. We definitely got a pretty good result. I'm sure if you try to measure gradient right now, there will be no gradient across that lesion. Patient is going to feel better because of this healthy profunda. Let's see if we caught anything in the filter.
So I'm sorry I missed that. We had a little trouble getting the filter out of the packaging. The retrieval device, but we got it. But so the point now is we're going to retrieve this, and then we're going to take another shot just to see what's happening. I think here the enemy of good is better here. I think we've done a nice result. I think we've demonstrated the techniques here that you may need. Obviously, our lumen size is more than adequate in terms of pre versus post. We've increased the flow into the profunda, and so far we've not distally embolized. I'm very careful to say that, because as we all know, when we retrieve this, it may be a problem. So Dr. Wiley's kind enough to give me a rail, and I'm just going to go with this catheter all the way down proximal. And in the EV3 device, unlike the Abbott device, you're going to obviously sheath the filter. You're going to grab the filter and pull it back. Okay? So here we go. So here we go. So
Very smooth passage all the way through the lesion.
So we're going to fix the filter, and then we're going to advance the catheter, right? And I'm just going to get a partial retrieval since I have stuff in here.
Yeah, that'd be good.
I think that should be plenty.
Once you're over the double marker, you're
I'm going
good.
to follow this slowly back, follow guys back. And I think this technique is important. I know that Anwar has spoken a lot about this stuff because the issue is that as the let me see the filter. As the filter comes back, and what George said can get caught in a calcific spicule, it's very important that you don't lose it.
Yeah.
So now it's there because you did a partial capture. Now what we normally do, can you show my hands? What I do is I bleed back the sheath, and then I flush. Can you flush this with this? And I flush my TUI. I know maybe overkill. But what we do is we want to make sure, pull back please. We want to make sure
that's an important stuff because the sheath may be the filter may be a little bit overflown,
right? And
some of the debris might be retained in the sheath. It's a great idea to back bleed it.
So now what we're going to do is we're just going to take a little picture. I'm going to set this up. You guys can see in the fluoroscopy. This is a very, I know Anwar deals with a very calcified. He deals with a lot of calcific lesions.
Let's see how it goes.
This is probably what he's used to dealing with. But this is very calcified. And you can see that what we're dealing with here. So we're going to inject. So Dr. Wiley's going to give us a little dye, maybe more saline, so we might have to do another one. So obviously, so we have
coming. It just went below the occlusion. That's
so there is an SFA disease, obviously, but the flow is definitely brisker, right, and better. And so I'm going to go down a little bit lower here. Show here. So the issue becomes is now whether offline we should fix this SFA, because obviously we're running on a little bit out of time, but again, that's not the point of our discussion today. So as we inject now, it's obviously still the flow is very slow, but clearly you have better filling of your vessels, and now you can see a nice 3-vessel runoff coming, or 2-vessel coming down. Diseased anterior tibial.
Probably a 2-vessel runoff, that's right. Very good.
Anterior posterior tibial. So now I'm just going to take a shot of the SFA and ask advice, since I'm lucky enough to have guys like Anwar to advise me now. I'm going to ask him whether he would fix this or leave it alone for this time being and see what we should do, since the flow is not as brisk as I would have wanted it to be. Because it looks like a focal SFA stenosis right there. Also a heavily calcified.
It's actually not so focal. The occlusion is focal, but then the post-occlusive segment is about 40 millimeters. That is not so focal.
So what do you think, Anwar?
I think what can make you feel better if you give nitro now, and you will get dilatation of the distal vessels, and you're gonna get you may get a brisker flow and a better feeling.
You know what? That's a great point, because you know the use of drugs in the peripheral space, we use it, but it's important to emphasize it, right? I mean, you talk about the distal vessels and how they help. Why don't you give a little talk on what are the drugs that you use?
You know, there is different cocktails. Some people use papaverine, and it does work. I usually use a combination of adenosine and nitro, and sometimes verapamil when patient is not bradycardic and ejection fraction is normal. The reason why I'm not using papaverine is because I usually use heparin during my interventions, and our pharmacy in our institution believe that it's not safe to combine papaverine with heparin. That's the only reason why I'm not using papaverine. But anyways, a combination of nitroadenosine and verapamil, this cocktail works quite well. And you get you dilate the distal vessels, and sometimes your flow gets much better.
So what we're doing here is we normally use nipride, but today we have none prepared at this stage. So what we're going to do is
nitro would be good.
So we're going to give nitro, as Dr. Babayev said. I'm going to give about 200 mics of nitro, and Dr. Wiley is going to flush it through vigorously, and we're going to watch for our blood pressure response. We have 5 minutes left, so what we'll do is we'll do this flush vigorously for a few minutes.
I think it's great. Okay, let me take a moment to remind all the viewers that they can view these cases again and again, and using the archive button of the website. Let me also remind them that in this website there's going to be information regarding registration for the upcoming complex coronary and vascular cases symposium here in New York, June 11 to 14. And we would I'd like you to follow this process here on the website. You will have very soon registration information.
Now, George, you can also see here that we followed his advice, and you see here flows much brisker through the SFA. Yes, there's a focal lesion there, and I think what we're going to do is follow what I think all of us would do here: send him home, see how he does.
Exactly.
Explain to him he has a residual blockage in the SFA that may or may not need to be fixed depending on symptomatology. Now, remember, his symptomatology was classic hip and thigh claudication. It was not calf claudication. Probably part of the reason is he wasn't walking far enough. So now maybe we may convert him to calf claudication, but maybe at a much longer distance than he was before, so we might have made him feel better. But clearly you can see Dr. Babayev's a clear suggestion worked really, really well here. We use nitro, we didn't use nipride. You could use nipride, verapamil, piperacillin, whatever it may be. So we're done.
I think that's great. And that's great. We use very complex atherectomy devices, 2 of them, filters, involving procedure already for about an hour. I think adding on another hour of SFA would be an overkill. I think, as you said, is a very great thing to just evaluate how the incremental clinical improvement is. And back to you for the goodbye from the lab.
Right. I just want to tell finally that just invite everybody in the audience to come to our conference on June 11th and 12th. Anvar's been kind enough to be our faculty for 2-3 years now, and he's coming back to us. We also have a fellows course on June 11th. Invite all the fellows who are watching that this will be available to you guys, and we'll reach out to you individually. And clearly that I think this educational program has really helped and grown well, and I really thank everybody. Of course, Anvar, thank you very much for taking time out of your busy day.
Thank you very much for inviting me. It's been a pleasure.
Jose, thank you, and obviously everybody here, thank you. And George, we're signing off from the Cath Lab, and we'll see you next month.
Yeah, I guess you'll see me in about 5 minutes, but we'll see everybody else in this conference via the Peripheral website on March 27. It is again a Wednesday at the same time, wherever you may be around the world. This was a super complex case of a mid-common femoral artery targeted by 2 atherectomy devices under IVUS guidance and distal filter protection, and also associated with final result is great with use of the angiosculpt balloon. The interventional team did a fantastic job, a great case selection. I think you can view this case as well as our other previous cases from us at the archive, using the archive button of this website exactly at the top of your screen. And again, we'll see everybody live from New York on the March 27 webcast, and we'll hope to meet and greet everybody in person at the live symposium in June. And registration information will be up in this website as well in the upcoming weeks. Thank you for attending.